Welcome to this episode of Stanford MedX Live for Tuesday, April 15th, 2014. This program is a weekly live recorded broadcast and tweet chat from the organizers of Stanford MedX, a conference that explores the intersection of emerging technology and medicine. The views and opinions expressed on this broadcast are those of the individual participants and not necessarily those of the Stanford University School of Medicine or the conference organizers. If you are joining us for the first time, a quick reminder that there is a simultaneous conversation happening on Twitter right now using the hashtag MedX. Sarah Kucharski, also known as Afternoon Napper, is the moderator of today's episode and will be taking questions from social media, so please make sure to start up your Twitter client to join in the online conversation and interact with today's speakers. Please also make sure to like our Facebook page at www.facebook.com/Stanford MedX. We also wish to remind you that registration for Medicine X 2014 is now open. Don't miss the year's premier patient-centered conference on emerging technology and medicine. Unique opportunities such as our masterclass program and our IDEO Design Challenge workshop have extremely limited space availability. You won't want to miss these programs and take advantage right now while our early bird registration pricing is still available until May 1st. Please note, you are watching a live online program and there is a delay between real-time events and the live stream you are watching. Tweets from our in-studio guests will appear before you see the real-time events they are tweeting about unfold on the video live stream. The topic of today's class on April 15th, Tax Day in the United States, is healthcare costs. With us today is a diverse panel of patients with insights into healthcare and healthcare costs. The goal of this program is to hear from them, have them share with us their views on these issues, and of course, to answer your questions out there from our viewing audience on Twitter.
I am Britt Johnson, and I will be moderating this evening's chat on healthcare costs. And I am one of the e-patient advisors for the Medicine X e-patient advisory board. I have been a patient for 22 years now. I've been living with two forms of arthritis, undifferentiated spondyloarthropathy, which is basically a fancy way of saying I have arthritis of the spine, as well as rheumatoid arthritis and chronic complex migraines. And if you've been following me the last days, you know that's what I've been dealing with. So I'm actually coming to you live from the couch today, so it's a little more comfortable for my bones. So I'd like to get right to it and introduce our wonderful panelists this evening to tackle such an important topic. We have Casey Quinlan with us. Casey Quinlan is the author of Cancer for Christmas, Making the Most of a Daunting Gift, a hospital medicine journalist, and one of the moderators of the Healthcare Price Transparency tweet chat, hashtag HCPT. She's an evangelist, mincing my words, for open data and open pricing in healthcare. We also have Meredith Gold with us, who is a sociologist, communications consultant, and working writer whose personal encounters with healthcare providers began when she was 8 years old. She has worked in and around the healthcare industry since the early 1990s and is a Platinum Fellow of the Mayo Clinic Center for Social Media. With us also is Nick Dawson. Nick Dawson, MHA, is a principal with Better, where he focuses on increasing empathy in healthcare. He's a former hospital administrator who has helped lead revenue cycle operations for a 14-hospital system. Today he spends most of his time supporting the Society for Participatory Medicine and working with Stanford's Medicine X program. So tonight, we're going to get right to it, and just to explain to you guys what we're going to be discussing a little bit, since you can throw your questions to us using the MedX hashtag, you can tweet your questions to Sarah Kucharski at Afternoon Napper, who will be feeding me questions throughout the live program. So for the first half, we're going to be talking about patient perspectives and realities for what that means, because I feel like though we preach it here all day online, maybe there's not quite a clear picture of what that actually means for us. So we're going to start out by talking about that. And then in the second half hour, we're going to start actually looking for solutions and sustainable healthcare costs. So to get right to it, my first question is, just because it is tax day, and we at Medicine X do have a bit of a sense of humor here, so that's why we're discussing healthcare costs on tax day. So a reminder, if you haven't done your taxes, they are due by tonight. But we'll roll into that a little bit more in a minute. My first question, I'm going to throw it to each of you, is do you currently have health insurance, and was it difficult to acquire and or maintain? So Casey, I'm going to start with you.
Well, I was uninsured for 5 years after cancer treatment, so that was what sort of started me down the road of the healthcare cost transparency piece. When healthcare.gov opened on October 1st, I think I was one of the first people to run into the blank screen of death, and I kept going and discovered that the original iteration had probably only been optimized for native browsers, so when I switched over to Safari from Chrome, it worked great. I have health insurance as of January 1st for the first time since 12/31/08. So I'm happy, but I'm not happy with health insurance in general as it stands now. I'll save the rest of that for later.
Sounds good. So that's the good intro to see where we all stand. And Meredith, do you want to answer that same question for us?
As I unmute myself. Can you hear me? Okay. Health insurance. I currently do have health insurance, and that's not why I got married, but it was certainly a side benefit. I have gone for years without health insurance. I've gone for years at a time where I have had to buy it independently because I went freelance as an independent writer and an independent consultant back in '89. And so since '89, I've either had it or not had it because I've had to pay for myself. So I've gone through brokers, I've shopped for it. I once tried to cut a deal with a client of mine and asked him if he would please bring me on to his insurance, and that wasn't going to work. And it's just been a crazy time. And then I got to a point where I realized why even have it, because the practitioners I was seeing at that point in the trajectory of my illness, I was diagnosed with fibromyalgia in '86, so I've had it for a really long time. By the '90s, I wasn't even seeing practitioners that were reimbursable. So I decided, why am I even spending this money on insurance? And that was a little bit like playing in roulette, because the 1 year I didn't have the insurance, I got slammed with unexpected MRIs for like $3,000 a pop.
Yeah, that's the interesting side here. So we've got kind of differing viewpoints, which I think is great moving forward in this discussion, or different experiences. So Nick, you're coming to us from a little bit different perspective. Not necessarily a patient, but I know you've definitely had your moments. So go ahead and answer that question for us. Where you stand with healthcare and so forth.
I am covered. I'm covered under a employer plan, and I wanted to experience the exchanges. So I'm also dually covered at least I will be as of May, under a plan from the exchange, which is I recognize a place of opulence, frankly, to be able to do that. But I thought it was important to be able to go through that experience and see what it was like. And frankly, I think having extra coverage is probably not a bad thing.
No, I'll definitely agree with you there. So just to let you guys all know, I'm going to be joining in the conversation a little beyond just moderating this evening. But where I stand with healthcare currently, so I was married just almost 2 years ago, and my wedding date was actually chosen around the ability to maintain healthcare for myself. So, take that and chew on it. That's a little interesting there. So my husband and I, we're guaranteed that we would have adequate coverage if it was by a certain date. And when we returned from our honeymoon, we learned that that was not the case at all. And his employer had actually fallen through. So returned from my honeymoon, and I had no health insurance. So basically since then, since the last 2 years, I've been struggling to maintain it in one way or the other. I've been fortunate to get on a major risk medical plan through the state of California because I'm a high-risk pre-existing condition patient. that's a whole other game because it has been a fight to maintain it. In the last year, they have accidentally dropped my coverage 6 times, including last month. I was completely uncovered and had to pay for everything out of pocket, which I got really creative to maintain my meds. So, I've had my battles back and forth with it, and I agree with Meredith, sometimes is it worth it or is it not, seeing what they actually pay out. So we'll move forward on that. I guess, Casey, I'll bounce it back to you here. Either now or at some point, looking back, what kind of healthcare costs have you looked at, in your lifetime? How is this actually impacting your overall, financial situation overall? Is it enough to actually write off on taxes, or is it not?
Well, the plan that I have, one of my goals in getting health insurance was to be able to have a health savings account. And one of the, I think, failures of the Affordable Care Act in this area is, some of it's driven by the state-by-state nature of healthcare insurance. And as a result, in my state, the best plans I could get that were HSA friendly were only bronze plans with pretty significant deductibles, out-of-pocket costs. So, for example, I pay a relatively low premium per month, and I am covered for the 10 things that you got to be covered for. But this would not work for somebody who had, say, your complex conditions, Britt, or any of the people that we know that have complex conditions, because my out-of-pocket as an individual with this plan is $6,300 a year. However, I can pay for that out of pre-tax money via the health savings account, and being that my only thing is mild hypertension. I mean, I'm a postmenopausal woman with mild hypertension. Alert the media. So I can be on a Walmart $4 special. So for me, but the thing is that in order to understand how all that works, I think most people don't understand how to buy insurance, and I think that that's sort of a big gap that's going to have to get filled in the current iteration of the ACA.
I think you're right as far as education of what you're actually getting and what you're actually paying for. It's not a one-stop all, this is what healthcare is. And trying to navigate that, even for me, is terribly difficult and exhausting. I'm fortunate that I will actually be switching back over to my husband's insurance, in a couple months here. Thrilling, but at the same time, we're having to make sure that we're making the right decision, like you're saying, that there is, adequate coverage. Who is it covering? Seeing that I am a chronic patient and I experience healthcare a little differently than a lot of other consumers would, or quote unquote, normal consumers, because I'm looking at, those specialist copays and different copays and MRI copays and so forth. So it is, you have to learn how to read it, and there's not enough education there. And, then the question is, so why is that? I think we're leading into the next one. Is what's being hidden from us that is trying to complicate it? And I don't know, Nick, if you want to even tackle that a little bit, from your end. Is there a little bit of a game that's being played there?
I want to make sure I understand the question, so I don't step in it. I might step in it anyway. When we're talking about things that might be hidden, or at least maybe less apparent to shoppers, do you mean from the provider side or from the insurance carrier side, or
not necessarily from the provider side, maybe from the hospital as a system, because I think that is billed very differently than my direct providers and so forth. So I guess the agreements they make with different healthcare groups, we're not sure what we're actually signing up for sometimes and what we're going to get until it's too late. So I don't know. Is there some insight there?
Well, I think you just nailed it, maybe more succinctly than if I prattle on about the history of the third-party system in this country. And it's a really complicated system, right? And so there are things that factor into it, like does the insurance carrier and that specific plan have a contractual relationship with a hospital, or with the lab company, or with the doctor? Those things can all be separate. So you can go to a doctor who says, yes, I accept your insurance. That exact plan you have, I accept it. And we can talk a little bit about how they might charge or pay at different levels for different plans. That's an interesting topic too. But let's say they accept your insurance, and then you go get lab work done. Well, that lab may not have the exact same contractual relationship, or may not have one at all. the hospital, if you end up having to go to have a procedure or a diagnostic test, may not have a relationship, or any of those. That could be kind of a matrix that can work in any number of ways. So, I would say that that's really the biggest challenge, is that we've got and I guess I'll show my hand here a little bit in terms of my biases, but we've got a very complex third-party system where one of those parties, the insurance industry, is spread out across a bunch of different companies and different products. And I'm not suggesting that's a good or bad thing. It's just another layer of complexity. I think in general, maybe I'd be a little wiser to say, or succinct to say, that just the very nature of what we're talking about as we try to introduce patients as consumers, as a consumer of a healthcare insurance product, and that's really what it is, that we haven't really built enough around the transparency to make us as consumers educated consumers. We don't know what we're buying, and that's not really a fair place to be from an economic standpoint.
Absolutely, and I think there's there's a lot of jargon thrown in there, and me as just being an e-patient and dealing with this every day and being a chronic patient, I've come to weed through and learn that jargon a little bit more, as do other patients. But even for us, it's daunting trying to sift through and actually see what we're getting. And Meredith brings up a really good point here. I'm about to go to you in just a second about what are then patients possibly lying about, because I can tell you, for instance, my diagnosis was kept out of my records for several years for multiple reasons, so that I could have access to certain drugs, and hope I'm not going to get anybody in trouble here, and so that I could have access to healthcare, quite honestly. So Meredith, I'll let you jump in there.
Yeah, I want to say a couple of things about that, and also that all business about patients as consumers. There's a big debate flares up every once in a while about, should we be called patients, should we be called consumers, should we be called clients, and I always probably cause a little bit of trouble by saying I have no problem with being called a consumer or a client if I have consumer rights, and if everybody understands that I'm buying a service. So you can call me a consumer, you're not going to hurt my feelings at all, just as long as you know I'm buying your product, I'm buying your service, and therefore I need the same information that I require from the car dealership, the people who are repairing my cars, anything like that. So that's a preamble to say that I have a long history, and it actually might be a bit genomic, of scrutinizing bills. When my father, blessed memory, my father died in 1998, and after he died, I was sitting and reading through his voluminous correspondence. My father was an ad man, he was a PR guy, and kept carbon copies of all the letters he wrote to Englewood Hospital challenging their billing on his kidney cancer. And so I sat down. It was very lovely. I got to read all my father's letters, and he was a great direct mail writer. So he had the paragraphs blocked, and he had pull lines and punch lines and kickers basically saying, what are you charging me for? Why are you charging me this? And didn't we discuss this already? So I come by this honestly. So I have, for decades, always challenged bills and actually do it beforehand. So when you ask, when we say we don't know what questions, what do patients do? We don't understand the language. We're not even asking the right questions. And some of the questions are very simple. When I need any kind of testing, which separate topic that I don't actually get anymore, but when I would get testing, my first questions were not, what is this for? Because I knew what it was for. Mm-hmm. It was, how much is this going to cost? Is this medically necessary, and that's why you're ordering it, or you're covering your butt? Which I understand, but let's be honest about what's going on here. And for how much will I be responsible? And I need that in writing, and I need that very clearly. So if your office needs to jump through some hoops to find out what the reimbursement is or was not going to be, then I need that information before I can make a decision about whether to get a procedure, especially if it's a procedure or a test that we're only doing so that your malpractice insurance is sustainable. Okay.
I think it's a definitely a good point, because I feel like sometimes, especially with chronic patients that do go into the clinic who are desperate, or say chronic pain patients specifically, when you're not getting answers and your treatment's not working, for so long, it seems like a part of the model has become, okay, if I'm going into your office, then I'm expected to deliver some sort of treatment, some sort of something to show that you were here, quote unquote, So basically, if I go into a doctor and they say, we can't, the right answer may be, we can't help you at this time, or, we need to adjust this a little bit. But instead, what they're going to do is run lab work and possibly run another test just to make me feel as though I was cared for. And I have been able to kind of sift through the difference of that at this point, but it took a long time for me as a patient. Every time I was told, let's do another x-ray, let's do another MRI, and then I realized, as you're saying, that it was just sort of to save face in a way, to present like something was being done, when in fact it's really just a band-aid to the larger issue. And that doesn't even bringing in the money on the other side. So Casey, I want to bring it around to you and talk just a little bit more about the realistic picture of what it's like, from engaging with patients online. What is it really like for them to live with these high healthcare costs that you see? What sort of things are they having to sacrifice, or what sort of decisions are they having to make?
Well, for the folks that that have been doing this for a while and are, I don't even know what adjective to use here, but who understand how to get at information, they're using tools online that help them at least identify some kind of ballpark on what's going on. The other thing is, until you start asking doctors questions about how much is that, they will not be educated and understanding that that is information they really need to provide to patients. And the other piece that is kind of missing a lot of the time in a lot of conversations about this, and it's almost like a Where's Waldo question, is that because of our very screwy third-party payer system that Nick referred to earlier, is that there really is kind of an arms race sometimes around how many times can we send this same patient for an MRI and bill for it. Not as though everybody's doing that. Please don't think that I have just tarred the entire industry with an idea of like bill padding. That's not it. But the problem is you combine CYA medicine, which is looking over, practicing medicine, looking over your shoulder, looking for lawyers, which really is, malpractice I don't think is as much of a litigation problem as it is another revenue stream for the insurance industry. But I think that people talking, giving direct information to each other, be it doctor to doctor or patient to patient, and the most important thing that somebody can do if they have a thing and they know that they're going to have to be dealing with their thing, is to go and find a community of patients with that thing and start asking, hey, how much is that? Do you know? Do you have any ideas?
Mm-hmm. Well, and I think that brings us around, to some of these medications and so forth. I'd like to hit on a little bit. So if any of you guys want to jump in, just let me know. But, specifically some of the medications that I'm on, range in the thousands of dollars a year. So one drug that I'm on, I'm on 2 injectable meds. One med costs me $10 a month, whereas the other one costs about $30,000 a year for my insurance. I don't pay that, luckily. I pay a much lower portion of that, but that brings me around to things like copay assistance programs. Are they truly helping, or is it, again, presented to almost save face in a way? I can tell you for one that I do not qualify for any of those copay assistance programs, even though when I did my taxes this year, my out-of-pocket medical costs were 3 times what I was able to earn last year. So I was able to write off 3 times what I brought in last year, and yet still I do not qualify for copay assistance programs. So, are things like this just sort of to save face in a way? Nick, go ahead.
Yeah, I'll jump in. I have some limited kind of firsthand knowledge on kind of the behind the scenes side, not the usage side of those copay assistance programs. But before we get to that, there's I am in no way qualified to talk about pharma costs, but I do think there's a bit of a sticky wicket here that's worth examining. Most of the pharmaceutical companies are unsurprisingly anchored or headquartered in North America or in Europe. And in most of the developed world, there are policy regulations in place that either limit the amount that a drug can cost or limit the amount of time it can be under protection or trademark, or don't allow that at all. So we see in some places in Europe and some places like Canada, and again, I'm not really conversant here, but we see things that allow generic meds to come to the market a lot sooner. What we hear from the pharma companies a lot of times is that that R&D is incredibly expensive, and if you look at some data, in 2013. They all spent in excess of $50 million. At least Novartis and Merck and Sanofi were all in kind of the 50, 60 million dollar range or more. Excuse me, I'm missing a zero again. Hundreds of millions of dollars in R&D and research. And what they'll tell us is that pretty much America, the United States, is the only market that they can capitalize that R&D cost. And I don't know how true that is. I don't want to try to validate that or get into an argument about pharma costs, but I think it's worth considering, right? Do we have an unstable economy when it comes to those things? And would new meds not come to market if we didn't have a system wherein most of the people in this country that are insured are paying an exorbitant price that the rest of the country can't pay or doesn't pay because of policies? I don't know. I think that is somehow upstream of the pharmaceutical assistance programs. I do think those programs are really worthwhile. I find that the things that really make them valuable are the nonprofit third parties who step in and work as an intermediary, like a broker. And we see those in most large communities, but they are hard to find. And there is a pride and dignity issue, I think, that sometimes prevents people from seeking that assistance. And there's a barrier to entry, too. That is, if you don't have insurance, you may not go to a doctor or a provider or an emergency department, so you may never get prescribed a med. There's some things upstream there.
Yeah, and I completely agree with you, and kind of what we're all quietly saying here too, is that as far as pharma is concerned, I wouldn't be alive without them, and I'm going to be the first to say that, and I would not be functioning as well as I am. But the true question is, if we're the only country here in the U.S., that's willing to shoulder those R&D costs, and that's the same thing that I've been told, and R&D, research and development for all of you out there. So to actually develop the medication, to research it, the many years, sometimes 20, 30 years to actually get to a drug development stage. So those are the costs that we're looking at recouping. But my question is, are these drugs actually benefiting the patient if by the time that they get to market that they can't even afford them? Does anybody want to jump in there? Or is that just going to be one that we let float out there? So I guess the next thing I want to jump into, Meredith,
go back there, Brett. Go back. Ask that question again. I want to make sure I understand it.
So my question is, if we're the country, if the United States is willing to, quote unquote, or can shoulder the research and development costs, and we're looking at billions of dollars that they are looking to recoup back, by the time that medication gets to market for the patient, and you're looking at a medication that is $30,000 a year, can that medication really benefit the patient if they are having to mortgage their house, if they are having to make the decision between buying food that week and their medication? Is that really a benefit?
I might spin it a slightly different way. There was a wonderful article in the New Yorker magazine, or New York Times magazine, excuse me, so the magazine of the New York Times that they, I guess, publish on weekends, about Sloan Kettering and the cost of cancer meds. And I can't quote the author, I'm sorry. But I think it was a really, really good study at a different way of slicing that question, which is, are we always considering the right meds? And in some, this is again a conversation I have no business commenting on because I don't know the details. But in some cases, there are some cancers that will respond to a couple different meds equally, or one med will have a very, very minute benefit over another. But you have to have a very small risk profile for it, and yet it will cost 10, 20, 30 times as much. And so I don't exactly know what to do with that part of the conversation, but I think it's worth are we making smart choices about the meds that we're being prescribed? Is it the only med that's available? If it's the most expensive one, is the marginal cost worth it? And there's a number out there called the number to treat. In other words, out of how many, one in how many hundred people will get benefit from this med. So, I don't know what the number is, but the number to treat for aspirin for a headache is pretty high. 90% of people will get headache relief if they take an aspirin. But there are other meds for which that number is 2 or 3 people. There are some statins for which that's the case. And I think if we don't have that that level of detail, it's really hard to make an informed choice. That goes back to Meredith's comment about being an informed consumer.
So Casey, I think you want to jump in here a little bit and on that one, and then I think we'll move on.
We also have a question that came in over the transom, and I think that what I'm about to say will address all of it, or at least a part of it. I think we're witnessing a shift. It's not going to be something that's going to happen quickly, but as more and more genetic profiling is available, i.e. pharmacogenomics, that different people's genetic profiles can predict whether or not that drug will work on that person. I think that that's going to open up some potential for finding the right thing. And also pharma's business model, and this is not like bashing pharma at all, but it's, it's the way science has worked. Pharma's business model has been to find something that worked pretty okay in at least 50% of the people who had that. Now, that's not really the best approach, I don't think, but it's where they are and how their trial structure works and how their scientific exploration works. So I think over time, as pharmacogenomics becomes more regular and discovers more genetic links to different things, and it's pairing with medication, we'll be able to see more targeted meds. But I also think that that will cut a lot of their research and development. If they put more into pharmacogenomics, I think that they get a lot more ROI, and I'll stop there.
I'm going to throw in one last thing, then we're going to move on a little bit. So the question that we had was from Chris Sebastian. Thanks for joining us this evening. So it was, I also hear that, quote, high prices are necessary to spur innovation in pharma research. Do you believe this is the case? I would say yes and no, because yes, while we need money to actually develop these meds and to get them to the market safely, which is a massive concern, of course, that takes a lot of money to get to that point, and I'm not naive about that. But what I would say is working with several nonprofits, specifically curearthritis.org, for instance, who their sole mission is to fund research on arthritis developments. They have for years funded research on small level grants. Previously they were $75,000 a year. They've been able to bump it up to $100,000 a year, but that's not a lot of money when we're talking about research and development that is in the billions for some of these other drugs. And my point being is that they are taking chances on other scientists out there with more radical ideas and other ideas, and that is just one subset of the patient community. And there's going to be all these other scientists out there with, radical ideas and so forth, but if they don't get noticed by the right people, if the research doesn't get noticed by the right people, then it won't get there. So I would say it's possible both ways. I think we could look at that structure a little differently, and maybe that's something we need to discuss a little bit. So I want to move on next to the idea of alternative treatments. So we've mentioned a little bit in here that we've been forced to make some choices due to our healthcare for various reasons, whether we take medications, whether we maintain our healthcare coverage because of that. So I know Meredith has had a little bit different trajectory with that, so I'm going to jump to her and let her jump in on that.
Yeah, alternative treatments used to be called complementary medicine. Back in the 80s, we were calling it complementary medicine. Just self-disclosure, I also worked for and wrote for the holistic health and complementary medicine industry, because it too is an industry, starting in the mid-80s and through the 90s. In my own personal situation, I found that acupuncture was just about the only thing that relieved my chronic pain and exhaustion that was connected with fibromyalgia. And I wasn't particularly interested in checking acupuncture out until I was sent by my local newspaper. It was also a healthcare stringer on the healthcare beat, and they sent me to interview a new acupuncturist in town who happened to specialize in orthopedic acupuncture and also immune disorder diseases and gynecology, which is treated in Chinese medicine with herbs, traditional Chinese medicine. I was so impressed by him, I figured, well, what the heck? I had just had back surgery as well. And I was about a year out of physical therapy, and I was still in a lot of pain with that, the fibro on top of it, blah, 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 blah. Anyway, I figured, what the heck? So I go to this guy, and he treats me, and I get off the table. I go about my day, and I think, yeah, all right, well, $50. That was $50, whatever. About a half an hour later, I'm standing in a line, and all of a sudden I realize that I am pain-free for the first time in years. It was so stunning to me that I gasped. I was pain-free. Fast forward, and in the early 2000s, I tried to get into a clinical trial for fibromyalgia where they were inserting devices basically to blast the body with electronic impulses to reduce pain. And I had a diagnosis of exclusion for the trial, but I was interviewed by the researcher who said, oh, you definitely have fibro and blah, 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 blah. I said, well, what do you recommend I do? She says, we tell people to go get acupuncture. Mm-hmm. So here was somebody in charge of a clinical trial. She said, go get acupuncture. I recently saw a rheumatologist. What was I thinking? Because I actually don't go to doctors anymore, but I recently saw a rheumatologist who said to me, oh, yeah, you definitely have that, and you're kind of a mess. I said, well, what do you recommend? She goes, we recommend acupuncture. Now, for years, acupuncture, she says, we also recommend massage. I said, don't touch me, I hate that, you know, type of thing. But my skin screams if somebody touches me. But again, therapeutic massage, acupuncture, acupressure, all that stuff is not covered. Is not covered. So, or it's not traditionally covered. I actually am in a healthcare, I have coverage now that does reimburse for the acupuncture. So I'm very, very grateful for that. I have an acupuncturist who is tied in with the insurance company. But for the most part, that. And then when you add the dietary things, years ago, I went to a nutritionist who told me to go gluten-free, and I laughed at her. And I said, oh, what's that, the new bright shiny? And she said, well, I have data. I said, good, evidence-based, bring it. She gave me some data. She said, there's some data that's very specific for reduction of pain for fibromyalgia patients who go gluten-free. I figured, what the heck? It couldn't get much worse. I had easily an 80% reduction in pain within 72 hours. It was so stunning that even I could not ignore it. I decided to go gluten-free. Okay, so what's the big deal there? Well, my accountant says to me, I don't care what you buy at your pharmacy. I don't care what vitamin supplements you use. I don't care if you buy gluten-free foods or pasta that's very expensive, whatever. Too bad. You can't. It's not a medical deduction. Not a medical deduction.
And that's something I've tried for the last few years, you know, and it wouldn't work.
I try to sneak it in.
Yeah,
I try to sneak it in. But
I find if it's purchased at certain places, you can, and that's actually a tip to some people out there, because some pharmacies now are starting to carry some specific foods like that that are more designed for, you know, a vegan diet, a paleo diet, a gluten-free diet, you know, so there are ways to get around it a little bit. Watch the IRS hate us this evening. You know, so the evening is quickly getting away from us. I want to make sure and jump to some other questions that we have here, and kind of move towards. So we have these issues that you know, trying to make decisions as far as paying for things with alternative medicine, massage. For instance, I had a massage this weekend. It was the one thing that stopped my pain for about 12 hours in the last 5 days. You know, so I completely agree there. But how do we go about solving some of these problems? We have a great question from Alan Brewington coming from Twitter. We all know the problems facing patients today, but what specifically needs to be done to change tomorrow? So, Nick, I'm going to come to you with the $1 million question.
It's not the $1 million question. It's the $17 trillion question, right? What needs to be done for tomorrow? I mean, I think it's a really big question. It's a really hard question, right? I mean, there's
down if you like. Yeah, I mean,
we may have to. I mean, I think there's a philosophical question here, which is if we look at there's a great line that came from again, I can't quote the author, I'm embarrassed. It was the Journal of Foreign Affairs, where a U.S. diplomat said, "Look, if you look at the numbers, we're an insurance company with a really great army. If you look at America," and that's pretty much the case, right? So the healthcare is the largest percentage of GDP of our domestic expenditure, followed closely by military defense. And we need to ask. One, is that appropriate? And the bottom line is it may actually be. In fact, maybe we need to be spending more on health and wellness. But the question is, where does that money come from? Are we paying it as part of our taxes in a socialized way, like a lot of countries in Europe would be? Are we paying it based on our income distribution? Are we paying it based on a need basis? I think it's a really big question. I think it's a really hard one to tackle. I'll add a little bit of maybe pragmatic political bias in here too, which is that as we get more people covered, and I want to go back to the question we started with at the very beginning of this program, which was kind of who has coverage and what does coverage mean? And the reason we ask that question is because in this country, coverage is the ticket to access. Whether we have a single payer system or whether we keep our third-party system with a bunch of different coverage providers through an exchange, that is the way you go about getting healthcare in this country, and that's neither good nor bad. It's just what it is. And as long as that's the case, the more people we add to the coverage pool, without getting all economic nerdy about it, then costs will come down because we have less people who don't pay into the system that we have to account for. I guess that's my long-winded way of saying I do think the ACA will help a lot with cost.
So I'm going to jump in real quick and then throw it over to Casey. I'm tweeting out something right now that I want everyone to see, if you want to jump in there. So talking about costs and bringing those down, this is a picture that I've used a little bit, and it's of one of my bills when I first moved to California. My first infusion treatment, which takes 4 hours for me to get one medication for 1 month, was billed to my insurance company for $62,000, $161.48 for 4 hours. So while we're talking about getting costs down and signing people up, the issue is, why are those costs so inflated there? And the interesting thing about this bill, if you continue to look at it, the next visit billed the exact same way, or at least keyed in the exact same way, cost a mere $4,874.64 for the same 4-hour treatment. So the point being is there are inflated issues in there that aren't going to be solved by merely signing more people up for healthcare. And it is, of my personal opinion, that the ACA needs to go a step further beyond just trying to get people covered, but actually trying to solve the greater problem of inflated healthcare costs, where we are not actually looking at what a service actually costs. I'm not going to purchase a piece of clothing that's exorbitant just merely because it has a name on it, because, well, that's not me. I'm going to purchase something that works. So, the issue here is, what am I actually purchasing then? What is my insurance company purchasing for $62,000 when apparently they're purchasing the same thing for $4,000? So, there's a really big issue there, and that the ACA has not begun to tackle. And if we want things to truly change in this country, that's where they're going to have to head next. So,
Britt, can I ask you just a quick question? I'm looking at your image, and I think, by the way, I want to applaud you. I think that's really bold for you to tweet out in a live conversation like this, part of your bill. That makes this really real, and that makes this an important conversation. So thank you for doing it. What I can't see is over on the left-hand side. I do see in the middle column chemotherapy, and I see two different things. Can you tell us, first of all, what's over on the left-hand side? Are they both the exact same treatment, the exact same dose? And secondly, is that the charge, or is that what the insurance company paid?
Okay, so I'll explain it a little further. So the reason I didn't show what's further on there is because there's personal information to the left. So those two are the exact same. That's what was so alarming to me about this. That's why I saved it. The only difference is that the first one that was billed at $62,000 was my first visit for this medication to that hospital. So I was a new patient, and it was like my, you know, this is my hazing, my introductory fee, basically, for my first treatment, if you want to call it that. And so it reads chemotherapy because though I don't have cancer and I have not had cancer, the drugs that I take for my autoimmune arthritis are considered chemotherapy. So we are in the same unit as many of the cancer patients. And it's billed the same way. So those are for the exact same IV medication. So that is billing for a nurse to be by my side for 4 hours within the hospital and set up an IV and administer the medication. That is also paying for the medication. So the interesting thing about that is it's basically paying for 1 day in the hospital and the actual medicine itself. So the disparity between those two bills makes absolutely no sense. And that's why I've saved this for that amount of time, because there's absolutely no reasoning for it, you know, going through the bill. So to answer your question, so Casey, I'll let you jump in here. So.
Well, I mean, this is a pretty big snake ball of an issue. But I will say that one of the things that, you know, and I sound like a broken record on this sometimes, but one of the things that I think we need to look at as a pathway to getting at a more accessible system across the board is to end, I mean, if we're not going to end third-party payer, fine, got that, no problem. But we need to end this sort of tiered system that we have where your access to real group insurance is through employer stuff, you know, employer groups, or you could go to the exchange and buy an individual plan. And if you look at the coverage models, I mean, granted, they're widely variant, the same way they are in the exchange, and state to state, it's going to be different. But if we end the employer mandate, which, you know, I mean, I could go on for hours about this and why we have it, but if we ended that I think would be a step in the right direction. But, you know, the actual costs issue, I think really you're going to have to go street level, and people need to start asking why. Not how much and why, and just keep saying how much and why.
Mm-hmm. No, quite frankly, at the time, and this was when I was starting to really become an empowered patient when this bill popped up, you know, and I think I was still scared to ask some of those questions of why, you know, at the time. And I can tell you from my perspective, and I am talking to every patient out there, a few months ago, you know, I was suddenly owing my hospital $8,000 for no apparent reason. And I asked why. And the interesting thing is I asked why on Twitter. And within a couple of hours, that hospital got back to me. And they said, let us get to the bottom of it. Within 2 days, they were auditing my insurance company. And it was solved. I did not owe the $8,000. So the point is, ask the questions. Don't just pay the bills. They are daunting as they keep coming through that door over there. And they stack up. I know how it is. But you have to ask the questions. And if you can't do it, get someone for you that can advocate for you. So, Meredith, do you want to jump in here a little bit? So I'm sure you do.
Yeah, it's the mantra. How much and why? How much and why? Yeah, that. And it's interesting, you said, you know, at the very beginning, you didn't feel comfortable asking that. And that is, you know, how do people become activists in this environment? And it usually happens when over the course of an illness, either an acute illness or especially when it's chronic, you or I spent years, I spent my 30s and my 40s in doctor's offices all the time. When I hit my 50s and now I am 63, I recently decided I'm not doing this anymore. I simply am not doing this anymore. I'm not going to get it treated. I can't afford it anyway. And that's my personal choice. It's not a choice or decision that other people might make, although I will note that now that I'm starting to talk about that a bit more, I am running into, it's mostly women, I'm running into other women around my age who are saying the same thing. I am not getting any more treatments. I am not going to any more doctors. I have spent decades doing that. I am not doing that anymore. again, it depends on where you are in the trajectory of your illness. It depends on where, it just depends on all of that. The choices I make at 62 or 63 are obviously weren't the choices I made at 33 or 43 or even 53. Which is why I think it's important for us who live, those of us who live long-term with long-term chronic illnesses for over 20 years, need to talk to people who are newly diagnosed, and I define that as up to 5 years actually, is newly diagnosed, to talk about what's it going to look like. What are the choices you need to make? What are the choices you can make? And a lot of them, finances shouldn't be the determining factor. Sometimes they are. Finances are the determining factor, but it is a factor. And it's something we need to talk about more.
No, and you and I have had this conversation separately that, you know, as far as where we are in our health journey, you know, I'm 20 years in as well, even though I'm so young, you know, and it's so I've learned certain things, but then, you know, my maturity and growing up is at a different level. So, you know, those are finally starting to mesh a little better, you know, and, you know, so I'm, you know, I don't have a problem asking the tough questions. I did get another interesting question from Chris Sebastian on Twitter again. He said, do you believe itemized transparency in billing is part of the solution? Can it start a conversation? I would say absolutely, because I can tell you for one, when I did get this enormous bill that I tweeted out, that was my first question, what is this for? And they wouldn't answer it. They said it's for your treatment, it's for what, you know, your doctor asked for, it's for what the nurses asked for, it's what you needed that day. I was told it was what I needed, but maybe it wasn't what I needed. You know, maybe if I was looking at, you know, that second apple juice that I asked for and it was, you know, $500, maybe I didn't really need that second apple juice. So, you know, little things like that, and granted, I hope I'm not being billed for the apple juice, but I'm not sure. You know, I know that's popped up on other things. You'd be surprised, you know, what you actually pay for things. You know, Tylenol can cost, just 2 Tylenol can cost $20 easily in the hospital. It's because someone has to give it to you, and it costs this and that, you know. So there's definitely things to consider, you know, if you are able to make those decisions while you're in the hospital. So, Nick?
And, yeah, Brenna, you probably noticed I'm chomping at the bit,
Yeah.
and if you saw me looking away a minute ago, it's because I was frantic with my calculator. It ties into what you just said, right? So why is a Tylenol $16? That's I remember the Nightline report in the early '90s when that became the thing, and that became the cause celeb, and it still is a really great example. And I like your call to action, Britt, which is, you know, if you have an itemized bill, you can begin to make some of those choices. But there's a couple challenges here that I want to talk through. One of which is the obvious part is a bill comes after care is rendered. And Casey, I love your mantra, how much and why. You know, the question then becomes, who do we ask that of? You know, the doctor arguably is not the right person to ask. Maybe they should be, but they're probably not going to have the information. But I want to, but I'm not, by the way, I hope that doesn't sound like I'm discrediting that. I think it is the question to ask, and I think having the itemization is the way to do it. But we need to get it upstream, and I'm doing some back of the napkin math here, so bear with me. But if I look at your chemo charge for $62,000, right? We can extrapolate a couple things, right? So if there was that a 5-hour infusion?
4 hour.
4 hours. Okay, so I've overcharged. I've overbilled. If this was a hospital and we were billing Medicare, I could be convicted of fraud. You know, 5 hours or 4 hours of it. I'm going to go with 5 hours because we'll give them a little extra. 4 hours of a nurse's time at the average national nurse salary of $80 an hour. It's about $400. If we really bump up the depreciation on the building, the cost of lights, electricity, the seat you're sitting in, and some of the other overhead pieces, we might get about $1,000 worth of true cost. This is what I'm trying to get at. What is the true cost of that time in the treatment? The IV bag and the needle and the tubing that goes with it, it's about $100. And an hour of the doctor's time, by the way, I'm sure it didn't take that, but let's be really generous. The hour of the doctor's time at a mid-level per hour price for a specialist is about $200. That includes benefits for them if they're an employed doctor. So we're at about $1,700 of cost that I can account for that period of time. So that leaves $60,461 unaccounted for. Is that the cost of the med? It can't be, right? It can't be. So where does that come from? The average hospital margin for nonprofit hospitals in this country is about 2%. So what we have to get at, I guess, is you know, the reason that charge is $62,000 one time and $4,000 another, or almost $5,000 another, is I don't know how to say this. So I'm trying to ask it as a question. That's not working. There's billing loopholes, right? And it's being used to prop up what is already a really small overhead because we just aren't paying for the right things at the right time.
Absolutely, and with that massive bill there, that's what is it, $88,000 total. I ended up paying about $2,000 of that, so it wasn't too terrible. But you bring up a point here, and Casey's asking, what medication it was, and it was for remicade that I was on. That medication, when it came down to it, cost my insurance about $4,000 a month, roughly. Give or take what state you're in at the time, and so forth. The interesting thing about that, it does come down to choice, and the bad thing, unfortunately, we're running low on time here. But the interesting thing about that medication is when I switched states, I was in Texas prior to that, and my doctor at the time knew that I could not afford it, but she knew that it was the thing I needed. And when I went in for the first day, the nurse asked me, all right, can you afford this? I said no. She goes, okay. And that was it, and I was never sent a bill. And the interesting thing about that is, so that office was, I don't know how they were making money, but they were taking care of their patients, whatever that meant. And the thing that scares me about changing some of these laws, healthcare laws and so forth, is are doctors going to be able to be philanthropists as well? I've been on the receiving end of that many times, fortunately, and I know a lot of people are, but are they going to come under fire, and what, sort of paperwork are they going to have to attest to? And Meredith, I see you're shaking your head, so I'll let you jump in here.
Yeah, I have been the very grateful beneficiary of generosity by doctors, and I think that goes to the other side of when you say how much, why and how much, why and how much, how much and why. The other part of that is to let the practitioner go, no, I've said to doctors, and I've said, I cannot afford this, and have gotten bills waived. I've gotten treatment pro bono. I've gotten, well, back in the day there were physician samples for medications, but and that's been for medical doctors and also dentists. When I did not have any health care and I didn't have any health insurance and I didn't have any dental insurance, I had to have some periodontal work done, which is not cheap, and I had a periodontist treat me for free. And he knew my situation, and that was a blessing. So I think it goes to, sometimes we get into this adversarial thing with practitioners, and sometimes we just need to ask, and ask in good faith, and ask with no expectation that it's going to come true. But when we give people an opportunity to do the right thing and to be generous, people will do the right thing and they'll be generous.
I completely agree with you, and I think that's the thing. I think we have to tell doctors, our doctors and other healthcare professionals, we have to get them on our page and say, look, if I pay this today, I'm not paying that. And I had this conversation with my neurologist very recently, and I said, I literally cannot drive to you today and pay for that medication and pay for the gas. So what can we do here to make this happen? And once you start having those conversations and being very honest, I think that's when some things are going to change. So I think we'll get some last words in here. Nick, I'll let you jump in.
I promised I would be quick, and I'm going to make two very quick points. One is, we've done it all night. I've been the most guilty of it, and that's we need to be careful not to conflate cost with revenue and reimbursement. Cost is really often a made-up number. It's a number that's what I tried to make a point a minute ago and didn't do it very well. It's the thing that it's the number that gets put out there so that services that don't make enough money to literally keep the lights on, you charge enough for your chemotherapy, Britt, so that Anthem and United and Aetna will pay it. That's not fair to those providers, either those insurance companies. We're not dealing with the right thing there. The last point I'll make is the one that Telephonoscope and Twitter reminds us of, and that's my personal bent. As long as we're making cost part of the discussion about healthcare, we're robbing people of their dignity, and we're making people feel like beggars, even people who have full coverage, and that just doesn't feel like a very human thing to do. So that's my personal angle.
No, some good points to end on. Casey, I'll let you jump in here and take this question from Afternoon Napper. She says, in all caps, yes.
Yeah, why would doctors ever assume that one can afford to pay? I think that this is a conversation that as humans, doctors and patients need to start having. I think doctors need to be aware and be willing to take questions. I think maybe they should ask if they're sensing hesitation on the part of a patient. We've got to work on this together. Join the Society for Participatory Medicine and listen to all of us.
Wonderful. So I know we could keep going on this conversation all night. We tried to jump on as many possible topics as we could throughout all of that, but I know you guys had many more questions out there, so I really appreciate everyone who tuned in live tonight and joined the tweet stream. Some really great conversation there. Do keeping that discussion going using that MedX hashtag. We'll be on there for the next half hour or so, jumping in on your questions. Also, I want to remind you guys that early bird registration is open for Medicine X this year, so if you want to come, now is the time to sign up. So get registered, and then you can see all these fabulous people, and we can continue this conversation then as well. And so I want to thank everybody, and don't forget to tune in this Thursday at 6 p.m. For another episode of MedX Live, but it will be the design class held by Larry Chu. So thank you again, and we're going to cut to a little bit of a wrap-up here, but signing off from here, and thank you from everybody here.
Thanks so much for joining us tonight for this episode of Stanford Medicine X Live. We'll see you back here again on April 22nd, 2014 at 5:30 p.m. Pacific Standard Time, when we'll discuss the topic hospital innovation, hospital needs, and how you can play a role in the solution. You won't want to miss this next episode of Stanford Medicine X Live. As a reminder, this program is made possible by support from the Stanford University School of Medicine, Department of Anesthesia, Stanford AIM Lab, Stanford Hospital and Clinics, and the Agency for Healthcare Research Quality. If you haven't yet done so, please take a moment to like our Facebook page at www.facebook.com/StanfordMedX so you can continue the conversation online and stay informed of program updates. From all of us here at Stanford Medicine X, we want to thank you for joining us today and remind you to join us again this Thursday, April 17th at 6 p.m. Pacific Standard Time for another edition of Stanford Medicine X Live, featuring a new healthcare design class from the Stanford University School of Medicine called Design for Health. This week, we are featuring Matthew Diamond, MD, PhD, from Misfit Wearables, speaking on the topic Designing for Wearability, with in-class moderator and e-patient Christopher Snyder. For all of you out there taking time to tune in with us tonight, thank you for joining us and being part of the conversation. Don't forget, registration for Medicine X 2014 is now open. Don't miss the year's premier patient-centered conference on emerging technology and medicine. Unique opportunities such as our masterclass program and our IDEO Design Challenge workshop have extremely limited space availability. You'll want to make sure to take advantage of these programs while our early bird registration pricing is still available until May 1st, 2014. A special thanks to our guest panelists this evening. From all of us at Medicine X, we'll see you next time.